Good afternoon, everyone. I'm going to present a study on accommodative insufficiency in pre-presbyopic diabetic patients. Accommodation is the mechanism by which the eye changes its refractive power by altering the shape of crystalline lens. During accommodation, ciliary muscles contract, allowing the zonular fibers to relax and the crystalline lens become more convex. Far point moves closer to the eye and to focus on near objects. If crystalline lens elasticity decreases due to aging or diabetes mellitus or any other factors, accommodative response reduces. The maximum accommodation that can be exerted is accommodative amplitude. Presbyopia is a condition which causes reduction in the amplitude of accommodation due to loss of elasticity of fibers. Presbyopia usually occurs after 40 years of age. In this study, the accommodative insufficiency in pre-presbyopic patients with diabetes is measured to know its prevalence, and the amplitude of accommodation between diabetic and normal individuals is compared. Our study is a case control study which included 50 diabetic patients and 50 healthy controls belonging to the age group of 30 to 40 years, and the accommodative amplitude was measured using the minus lens method. Data was analyzed using a 2-sample t-test and a chi-square test to compare the accommodative insufficiency and the amplitude. Minus lens method was done using negative spherical lens, which were added until the subject cannot maintain focus. Reduced Snellen's chart was used, and the measurement was obtained in diopters. Our study included patients between the age group of 30 and 40, those without diabetic retinopathy, and patients with hypertension and other systemic diseases affecting the eyes, and previous ocular surgeries were excluded from our study. And the Hofstadter formula was used to compare the amplitude of accommodation for a given age. And coming to the results, the table 1 represents the comparison of gender and diabetic status with respect to amplitude of accommodation. Males, the mean value was minus 4.31, and in females, the mean was minus 4.32, and the t-value showed no statistical significance. In diabetics, the mean value was minus 3.73, and in non-diabetics, it was minus 4.84, showing statistical significance. Table 2 represents the accommodative insufficiency according to the gender, and the chi-square test showed no statistical significance here. Table 3 demonstrates the accommodative insufficiency according to diabetic status, and the chi-square test here demonstrated statistical significance. Our key findings of the study are significant reduction in accommodative amplitude in diabetic patients, and the results also show that accommodative insufficiency was independent of gender but dependent on diabetic status. The possible mechanisms could be impact of hyperglycemia on lens elasticity and ciliary muscle function. Microvascular changes in the eye may impair accommodation. Implications are diabetic patients may need earlier corrective interventions for near vision tasks and routine eye examinations for diabetic individuals to detect the early accommodative insufficiency. And I conclude that diabetes accelerates age-related decline in accommodative function in pre-presbyopic patients. Early intervention is the key to preventing further vision deterioration. Here are my references, and thank you.